Hi everybody, it's me. We are starting our video for tonight, and I'm just waiting for Dr. Roy, who will be joining us in a moment. I did want to say that in case you haven't seen me post about it, I got our website up. So it's Psychiatry Network, etc., which is really exciting. It's a place where all kinds of things. So we have a blog, and I'm still taking submissions for that. But we'll be having new blog posts at least once a week. We can also get people registered for the women's conference. So if you are thinking about going, there's information on the website about the conference, and you can register. You can sign up for the hotel room like right off that, which is great. I'm personally super excited about the conference. The topics that we have for the sessions are really great, and we are putting a lot of group stuff together, small group, big group. And for those of you guys, if you're a resident or a fellow and you have heard about this women's conference, I didn't talk about it that much in this group. It's mostly in the women's group that I've been talking about it, but if it's something that sounds interesting to you, check it out on the website. It's Psychiatry Network, etc. And if you think that it would be beneficial for you to attend a women's psychiatry conference, then send me a private message. I will figure out how to make the funding happen for you. I think a lot of residency programs, I'm reaching out to some program directors. I'm a residency program director myself, associate program director for the Loyola program in Chicago, and I know some of the programs would be very supportive of sending a resident to go. So if you are interested, just send me a message and we'll make it happen. All right, so I think Dr. Roy is joining us right now. Her Facebook name is Roy Cans. Hi.
Hi.
Hi, how are you?
Very good, Christina. How are you?
Good, good. I was just saying your Facebook name is Roy Cans, but your real name in real
Mm-hmm.
life is Kamalika
Well,
Roy,
Roy.
right?
Yeah, actually I
Kamalika
changed.
Roy.
Yeah, right. I
Yeah.
changed it because sometimes patients can find me
Yeah.
with my
No, that's
first name,
smart.
so
Yeah, very
that
smart.
was intentional.
Yeah. Okay, so I wanted to just read to you guys Dr. Roy's bio. Dr. Kamalika Roy is a faculty at the Department of Psychiatry in the Oregon Health and Science University in Portland, Oregon. She did her residency at Wayne State University in Detroit, Michigan, and a CL fellowship from the University of Michigan in Ann Arbor. She works in a neurogeriatric inpatient psychiatry unit at the Oregon State Hospital. She teaches medical students, residents, and CL fellows at OHSU along with her clinical work. She is also pursuing a master's in clinical research at OHSU. She's interested in observational studies and statistical methods and design, and she's active in several committees and special interest groups at the Academy of Consult Liaison Psychiatry. So, oh, I didn't know all that about you. So, thanks for joining us tonight. And
Mhm.
why don't you tell us what article you are presenting and get going?
Okay, thanks for joining everybody. Today I'm going to talk about the study that happened between 2009 and 2013 in 8 different centers across USA and Canada. And basically it's a drug trial. And then they looked into the effect of citalopram on agitation in Alzheimer's disease patients. So it was published in JAMA back in February 2014. It looks like it's a key study, though the results are not that exciting, but that's about every study, every clinical trial. I think if it is done in correct way, that should be the real expectation. So anyway, I am going to get started with a brief description of what they wanted to see and how they measured the outcomes. So they recruited 186 participants, and the study was randomized. It was a placebo-controlled, double-blind, parallel group trial. That means there was no crossover. So one group consistently got the medication, the other group got the placebo parallelly, happened at the same time. They divided these 186 subjects in two groups. The study group 94, placebo groups had 92 subjects. They followed these two groups for 9 weeks, and they began a dose of citalopram at 10 milligram per daily, and then they planned the titration over a period of 3 weeks up to 30 milligram daily. I'll talk about the attrition. So not that everybody got 30 milligram per day, or whoever developed side effects or whoever did not tolerate the medication, they got out of the study. And there is a supplemental table. If you guys go online on PubMed, you can find the supplemental table which talks about the specific side effects and their numbers. So this is the premise of this study, and why we are doing this. Pretty simple, that agitation is something that we treat with antipsychotic medication. Again, we know that there are a lot of side effects and risks associated with that. And also interesting that there were quite a few studies which looked into the efficacy of antipsychotic medication in this kind of agitation and Alzheimer's disease. Actually mixed. Actually showed some improvement, some of them not. So it's really unclear that how much we can help the agitation with different kinds of medication. That's why they wanted to look into a different group of drug, and also a little bit more about SSRI, use of SSRI in Alzheimer's disease patient. There have been quite a few clinical trials which included SSRI in Alzheimer's disease. Some of them, there were like smaller trials, I would say, and some of them were not exactly clinical trials, more like an observational design of study. They looked into the effect of citalopram, and again, some of the studies showed some improvement in agitation, some of them did not. So the result was mixed. So that was the premise of doing this multi-center, really big study, which went on for so many years in 2 different countries. The study was funded by NIMH and NIA, and you can read about the conflict of interest of all the authors, which is pretty long list. And I mean, that doesn't mean anything because citalopram, they use the generic citalopram, and it's been in market for a very long time. So coming back to the details, so this was the premise. So now, over a 9-week period of time, they measured 2 primary outcomes and quite a few secondary outcomes. The analysis of all these outcomes were not discussed in this paper. They only discussed mainly the primary outcomes and 3 or 4 of the secondary outcomes in this paper. But they have a lot of other papers. If you go in the PubMed and type this study's title, then you can see there were other papers. This was the very first original paper, but after that there were many subsequent papers and analysis that they published. Among the primary outcomes, they looked into 2 different scales. One is called Neurobehavioral Rating Scale, Agitation Subscale, NBRS-A, and the second one is Alzheimer's Disease Cooperation Study associated CGI. We know about CGI, which is Clinical Global Improvement, which is pretty widely used scale, but it seems like they used an Alzheimer's disease specific CGI to make it a little more valid. So these are the 2 primary outcomes they looked into at week 9. There are secondary outcomes they looked into. One of them is Cohen-Mansfield Agitation Inventory, again, very commonly used in clinical practice and research. The second secondary outcome is Neuropsychiatric Inventory, NPI, again, agitation subscale, to make it more specific to the target symptom that we are trying to treat. The third is ADL, again, it's a very common and clinically used. The fourth one is MMSE, to check whether the drug changed anything cognitively in that 9-week period of time. The fifth one is caregiver distress, which they again use the NPI scale, but they use a different subscale of that. They also looked into several other outcomes which are not necessarily analyzed again in this paper. They looked into the QT interval, they looked into the total dose of lorazepam, and they also looked into the number of falls, if that was different between these two groups. At the end of the 9-week, regarding recruitment, let's talk about recruitment who got into this study. So they actually included all the probable Alzheimer's disease diagnosis patients, and the diagnosis was done by, let's see, the diagnosis, was done by National Institute of Neurological and Communication Disorder and Stroke, Alzheimer's Disease and Related Disorders Association. It's on page 3 of the article. And this patients actually had an MMSE score with a wide variety, starting from 5 to 28, which seemed very interesting to me. I mean, so there were different types of cognitive status patients that got into the study. Nevertheless, they all had a clinically significant agitation, which would qualify them for some other trials for antipsychotic medication. So what they tried to kind of make sense that these patients really had agitation, not only like irritability or like symptoms of confusion, but they really had clinically severe agitation, which would need some kind of medication. I think they did a great job in that area. But the wide variety of cognitive impairment was kind of interesting because that can impair the result of the secondary outcome that they're trying to look at, the MMSE after 9 weeks. So this is and they excluded everybody who was on antipsychotic medication from before, who had some psychiatric disorder, who had some psychosis, who had some previous history of psychosis other than Alzheimer's disease and were taking antipsychotic medications and so on. So there also they did a good job. They did not exclude a lot of people, but they like their inclusion criteria was robust in my mind, other than the MMSE. Now, the method of study, after recruiting these people, they followed them up and they titrated over a 3-week period of time, again, which was kind of interesting for me. I don't know, like clinically, it's a little different than what we do in a research protocol. But definitely clinically, for my older patients, especially with dementia, I would not be able to do that, like robust titration that quickly from 10 to 30 milligram of citalopram. They did not explain why they went up to 30 and why not 40 or why not 20. So, what was the rationalization of 30? In this article, they did not explain it. Probably they had a rationalization, but probably they did not write it down here. And other interesting thing is, so they went on recruiting, and after recruiting 138 of subjects, FDA actually issued an advisory regarding QT prolongation effect of citalopram. Then from that point, they actually had a QT and a baseline EKG and a 9-week and EKG for all the other subjects after 138. So a total number of, let's see, 48 subjects actually had a baseline EKG to compare with their 9-week EKG. All other previous subjects did not have a baseline EKG. So here the sample size for that baseline EKG calculation, that analysis is way different than the total intent to treat population that did the analysis on. So now they also looked into, I think it was pretty cool, in the placebo group and also in the control group, they simultaneously maintained a lot of psychological treatment. For example, caregiver education and regular meeting with caregiver and ask them about how things are going. And then 24-hour availability of crisis management, counseling session for each scheduled study visit. So they continued doing all these things throughout the study, which I think was a really cool thing to include. So after 9 weeks, what was found? I'm going to make it very simple so that you can directly go to the questions and answer them, because most of the questions are related to the outcomes. So I made a list of what they actually found. In primary outcome, so now we are looking at the neurobehavioral rating scale agitation subtype. That improved, and the improvement was minus 0.93. Remember, the higher the score in this scale, the worse the agitation is. So anything in minus actually says that the agitation improved. So they found a mean improvement of minus 0.93 with a 95% confidence interval between minus 1.80 to 0.06. I'll just briefly say what does this mean. So whenever we do a study, any type of study, observational or clinical trial or whatever it is, we do not treat billions of people. Though we are trying to treat billions of people after the study result, whatever we are trying to get from that study. So we actually randomize, we take the most representative sample from those billion people and try to come up with a number. This is the mean number that we are seeing, minus 0.93, which was the improvement in that agitation subscale. But how precise was that number? That is expressed through 95% confidence interval. What it says that if this mean is valid, then there is a chance that 95% of the values, no, we can actually say with 95% confidence that the true value of this improvement will fall between that range. So smaller the range is, the narrower the range is, the result is more precise. So that's why I wanted to kind of tell you to also notice the range, not only the mean value. So if the range is narrow, that tells you the result is more precise, whatever your observation result is. And of course, there is a p-value, which is not always like the gold standard of finding out a precision for any study, which is statistical significance, but it doesn't translate into clinical significance. So their p-value was statistically significant for this measure. Coming to the second measure is CGI, global improvement. Again, the Alzheimer's disease modified global improvement. That measure also showed statistical significance with an odds ratio of 2.13. And they also did a sensitivity analysis. I'll explain what that is. And still with the sensitivity analysis, the odds ratio was 2.10. So it actually improved the odds ratio. That means the risk of having an improved CGI in the study group when compared to the placebo group. So these two measures were, I would say, like robustly statistically significant. Coming to the secondary outcomes, again, we have another agitation inventory that they checked, and that also improved. It showed an improvement of minus 2.38 with a kind of like a wide confidence interval range. So though the p-value was significant, but the confidence interval was pretty wide, wider than the previous confidence interval range. Then coming to the total NPI score, that also improved, but the subscale NPI agitation did not have a statistically improvement. Again, the NPI, the range, if you guys see, the confidence interval range was kind of wide. It was just saying that the effect is going to go away at some points. So in agitation subscale, it went away. So the total NPI improved, but the agitation subscale of NPI did not, which is kind of like, yeah, I mean, it almost beats the purpose. But again, that's the secondary outcome. It's not the primary outcome. In ADL, there was no significant improvement. In MMSE, they found some worsening, actually, cognitive safety. So the study group had a lower MMSE mean, again, with a confidence interval pretty narrow. So what does that mean? Again, we are checking somebody's MMSE in 9 weeks, and I'm not sure whether that change will be even clinically that great. Anyway, and we had to remember that to start with, everybody's MMSE was all over the board. I mean, somebody had 5, somebody had 28. So, and I can tell you that the placebo group actually had a significantly lower MMSE than the study group to begin with. So, and the study group then worsened. So it's kind of hard to say what exactly happened with the cognition with this citalopram clinically. And caregiver distress, they found no significant difference again. And interestingly, QT interval, they actually found a mean of 18.1 millisecond worsening in the study group. Again, no need to be like so concerned about this 18.1 millisecond number, I would say, because first of all, they had the EKG, the QTC number only in 48 patients. So the total sample was really small. The second thing, again, the confidence interval is so varied. It varied between 6.1 to 30.1. So it's a wide variation. Somebody's QT worsened by 6, somebody's QT worsened by 30, which is kind of an interesting thing anyway. And then they did not mention whether that QT prolongation was associated with any variation in heart rate, because otherwise it's hard to say. Probably somebody had a baseline long QT anyway. So unless there was a bradycardia, it's hard to say what was actually the clinical significance of that QT prolongation. But either way, as now we know that citalopram does have an advisory from FDA for QT prolongation that actually can have some medical legal impact in the practice if we have to treat these older patients with high dose of citalopram for a long period of time. So these are basically the outcomes they found in this paper. And as I mentioned, the total use of lorazepam didn't show any significant difference, but they did not include the analysis in this paper. Fall risk, the total number of fall was significantly more in the study group than the placebo group. There is some mention of the number of falls and how many patients got into that attrition area in the supplemental table. However, there is no official analysis for those numbers in this paper. And they mentioned that they are going to just analyze some of the outcomes, not all of them. So they did have a plan to come up with other papers later on, and that's what they did. Well, so take home from this study, I would say it's a well-designed study. I mean, all research studies will have some kind of a lot of confounding factors, a lot of flaws in design and so on, but the study is not design-wise, it's a well-designed study. But there are few things we have to kind of remind ourselves before being too excited or too disappointed with the results of this study, that these are again just the statistical significance differences may not translate into clinical significance, especially when there were almost like a mixed result when it came to the outcomes. Some of the agitation outcomes improved and some of them did not. Some of them kind of stayed at the board margin. So there was not a really robust difference, I would say, even with the agitation subscale overall. But then other things like falls, use of lorazepam, and then QTC, if we look at all these things, I think the dilemma still stays in real clinical world, whether to treat an older patients with Alzheimer's disease with at least 30 milligram of citalopram. What the study doesn't say is whether it's safe to use 10 milligram of citalopram or 20 milligram of citalopram. So what happens if we go a lower dose? What happens to those risks of QTC prolongation or falls, etc., or MMSE? It doesn't explore that part. So definitely there is also room for using citalopram for agitation in Alzheimer's disease, but the study might not be helpful in talking about the lower dose. One interesting thing, if you see on page 19, where there is this figure 2, if you guys have the paper with you, it talks about the differences. It shows the differences in two groups. The solid bars are for the study group, and the vacant bar is for the placebo group. If you notice, everybody's agitation symptoms kind of went down. I mean, it's a strong placebo effect. So everybody's agitation score went down. It's not, I mean, almost parallel. These two lines are almost parallel at every point: 0 week, 3 weeks, 6 weeks, and 9 weeks. So, which is kind of interesting to me. But what was, I think we had to notice that the stars in between these bars are actually the mean values, but the upper end and the lower end of the bar, again, describes that 95% confidence interval, the range of any change. So if you look at the upper and lower end of the bars, actually in placebo group, that did not go down, that did not improve significantly. But the mean value kind of parallelly went down. They didn't explain it much in the study, the description of it. Well, so this is overall what I got from this article. If you guys have any question,
there's one comment, not really a question, but a comment from Romy D. Rain, who just said, as a geriatric psychiatrist, I have yet to see SSRI alone be helpful for clinically significant agitation, especially in nursing homes. Agitation is a heterogeneous construct, and if it's due to underlying depression or anxiety symptoms, maybe this will help, but not if driven by, say, unmet needs or psychosis, which may not be obvious.
I totally agree with Romika. She's a friend. Hi, Romika.
Oh, okay.
So,
yeah.
Yeah, I am yet to see that as well. Yep.
Yeah. And we have another geriatric psychiatrist, Il Canguro Bianco, who says that I have yet to see that I rarely have I seen SSRI alone helps with neuropsychiatric symptoms, with the exception of comorbid depression and anxiety as a thought. So it sounds like you guys all are thinking along the same lines, which is great. The only, I had a question, or maybe just a comment. You were talking about the dosing for the citalopram. Do you think that had to do with the FDA warning that has come out about citalopram? Maybe that's why they limited it?
Well, they decided the protocol before the FDA warning came out. So they started in 2009 and the FDA warning came out in 2011.
That's right. Okay. Okay.
Yeah.
And then we did have one question from Sapna Porawat Rajput, and she asked, what would you use?
Oh, well, I mean, I was trained in University of Michigan where the DICE model, the DICE, DICE model was developed by Dr. Kill. So I usually follow that when it comes to agitation in older patients. And though I'm a CL psychiatrist, I actually, my day-to-day work is with older patients. I have never used SSRI for agitation. Yeah, I have used short-term, as Romy said, when all other factors are taken care of, like sleep. I think sleep is the biggest reason, which we often overlook. Most of these agitated patients have an altered sleep schedule. They all sleep during the day, nap during the day. If they do not sleep, at least they nap most of the part of the day. They have no activities during the daytime. And then they're up, their agitation starts somewhere around 7 o'clock. So this is the known story. So I try to change that, and I have very strong nursing support. My nurses are almost one of the best ones in this world, I feel like.
Oh, that's good.
So so they work very hard to keep these patients active throughout the daytime. And that actually takes care of most of the agitation, I must say. Sometimes I add melatonin at around 8 o'clock. So changing the circadian rhythm and keeping them active during the daytime is something I really heavily depend on. I also use physical therapy very frequently, exercise during the daytime, at least for an hour. So that actually helps agitation a lot, believe me or not. All these are non-pharmacological, basically. But if I have to use something, my favorite probably is going to be low-dose risperidone.
Right.
Again, for a very short period
Yeah.
of time, of course, I would try to taper them off eventually. But that's my like go-to drug for it. And I'm pretty sure everybody has one.
No, mine is also risperidone, so
Wow.
probably need to expand beyond that. But
Mhm.
and Romika said, Dr. Roy, great presentation. Do we know why they use this NBRSA? I tried looking it up and it was used in closed head injury cases first.
Yeah, so MBRS probably is the parent skill they're talking about. That MBRS has an agitation subskill. That's the one they used in this study. They do not necessarily use the TBI one.
Okay. And a couple of people were asking what the DICE model is. Or
Yeah, I'm
DICE.
going to look up, DICE model. I'm going to look up and send it in Facebook so that people can, it's a pretty,
Yeah, if you have a link, that would be great.
yeah, and that's going to be, I think, yeah, this is a really, really good link. It's the official link. Let me send that.
And somebody else was asking what your usual dosage of melatonin is.
3 to 6. Here you go.
Google DICE model dementia. Okay, great, thanks. Program for Positive Aging.org.
Yeah.
Okay.
Yeah, that's the Michigan Geriatric Psychiatry specific program.
Okay.
And
Yeah,
it's
I've
a
never heard of
really,
that,
really good
so
program.
great.
Yeah, I think the person who actually first proposed it, she did like plenary session in APA or APM, I forgot which one. Yeah, describing the DICE model. So it was pretty well received.
All right. Well, thank you. That was great and informative. And I believe, are you signed up for another article later?
Yeah,
No?
yeah, I'm
Okay.
signed up for it, but I still have to check whether I'm on call on that day or not. I'll
Okay.
email,
Okay.
I'll
Let me
email
know.
you or Rebecca
Yeah.
for that.
Okay.
And the questions, people will do it themselves and they will give the answers. Is that how it works?
Yeah, so there's 3 CME questions. The link is up at the top of the post through the American Physician Institute. And if you watch this video and answer the questions, you can get 0.25 credits of CME for each video. So it adds up
Okay,
if you do
perfect.
them all. Yeah. All right.
Let me
Well,
know if
thank
you have
you.
any question about the questions.
Okay, sure. Yeah, people can always post questions in the comments and try to get to them. So thank you.
Thank you, Christina, and thank you
Oh, thank
everybody
you.
for joining.
Yeah, have a good night, everybody. Bye.
Good night. Bye.